Everyone, we're just waiting for more folks to enter the meeting, and we will get started in a couple minutes. We would greatly appreciate if you can share where you are joining us from, specifically what hospital you're joining us from. Thank you so much. Hi, folks. We're just having a little bit of internet troubleshooting, and we will get started in a minute. Thank you for your patience, and thanks for being here. If you didn't already, please share what hospital you're joining us from and where. So hospital and country. Thank you so much. All right. It looks like Dr. Nick Maxwell has joined us. If you can please mute yourself if you're not presenting, we would greatly appreciate it. Welcome everyone to the Continuing Medical Education on Stick Journal Club. My name is Jess Pelletier. I'm the African Medical Coordinator for Techies Without Borders. And Dr. Nick Maxwell is also on here. He is the Medical Education Coordinator for Techies Without Borders. We're a nonprofit that delivers free continuing education. And many thanks to Dr. Jimmy Adiera, who's the SEED Global Health Coordinator, who gave us permission to share our invitation on the EMS Echo group chats. It looks like that's really helped boost our participation today, which is fantastic. We really encourage people to chime in with questions or comments in the chat. You can also raise your hand if you have a question during the session. If you did not already, please put in the chat what country you're from and what hospital you work at. Today, we're going to be talking about the judicious use of IV fluids, meaning when do we actually need them? And with that, I'm going to turn things over to Dr. Nick Maxwell, and we'll get started. Thank you so much, everyone.
Jess, can I actually have you pull up the slides? My bonus adventure. So my internet actually cut out, so I'm having to borrow somebody else's computer, and quite apropos. So I'm hoping Jess can pinch it with the Google Slides. Are you able to do that, Jess?
I don't know if I can moderate the chat and do that at the same time, Dr. Maxwell, but I will try. I'm not sure if that's going to work. Let's find out. Yeah, it won't let me see oh, no, I can see the chat at the same time. All right. Go ahead.
All right. So thank you everyone for coming. I'm really excited about how many people we have here today. And as always, we like this to be a discussion. We don't want this to be just a presentation on how we might do things in certain settings. We want this to be an interinstitutional and international knowledge sharing. So that way you can share how you do something in a certain setting and learn how somebody else does something in different settings. So that way you can learn new things to apply to wherever you might be working with, whatever resources you have, because I might have resources you don't have, you might have resources I don't have, and that's why we're here to learn from each other. And so we'll get rolling for today. So if you can move forward, Jess, I think 2 slides because the first one's a welcome slide. Try and figure out how to get those. Okay, so we're going to start with some cases. The first one is kind of a teaser, so to speak, while we're having people kind of continue to come in over the first few minutes. But so the first case is a 32-year-old male presents to the emergency department reporting insatiable thirst. He has a history of schizophrenia and depression. On exam, he's got moist mucous membranes and his vital signs are within normal limits. We'd like to know, and you can put it in the chat, you can speak up, but what is you think the next best step in management is, and what do you think might be going on with this person?
And feel free to chime in out loud, or you can write in the chat.
Absolutely. And I'm going to see if I can do more troubleshooting here so I can take the slides. So one of the things that this could be is actually primary polydipsia or psychogenic polydipsia. So some people, particularly those with a history of mental health problems, can actually have a severe drive for thirst in the absence of being volume down. And so sometimes you'll actually see people who are hyponatremic from how much water they're drinking just upon their own volition. And one of the first things to do sometimes is to fluid restrict them and get labs to figure out what they're to assist in the volume assessment. So for example, if you find out that this person is hyponatremic and hypervolemic, that could tell you one thing versus if they actually seem like they're volume down, that could mean something entirely different. So the idea behind this case is to recognize that just because common things being common, somebody comes in, says they're thirsty, doesn't necessarily mean that they're underhydrated. All right, let's move to the next slide. All right, and so the second case is a 76-year-old male with a history of congestive heart failure and recurrent urinary tract infections leading to sepsis in the past, who presents to the emergency department with 3 days of lethargy, dysuria, and decreased oral intake, as well as today they were found to have lower blood pressure. We'd like to know what you would want to do for this patient and how you would decide how much fluids to give if you're going to give any. Because today the name of the game is fluids. If we're going to give them, how much we're going to give, and so forth. Yo.
Feel free to chime in out loud or in the chat. How would you decide what you'd like to do for this patient? How much fluid, what type? All right, Nick, do you want to go through your logic on this?
Sure, yeah. So with this patient, one of the things that strikes me here is that this could be a patient with sepsis, right? They could have a urinary tract infection again, leading to sepsis. And so the idea here was to lead you towards the idea that they might be infected. And oftentimes with sepsis, one of the really important things that we do is give fluids. And actually, this is really controversial on how much fluids we give people. In the United States, this is oftentimes driven by the Center for Medicare Services, which is one of the main insurers in the country that reimburses hospitals for the care that they provide. And oftentimes it's thought to give up to 30 milliliters per kilogram of fluids IV. However, this is actually pretty controversial because some people feel it doesn't always improve outcomes. And especially in patients like this one who's got a history of heart failure, uh, they might not be able to tolerate that much fluid. So where I work, it is not uncommon for me to see people with an ejection fraction of under, not just under 40%, but I'll get patients with ejection fractions between 10 and 20%. And they might weigh 80 kilos. And so giving them 2.5 liters of fluid IV as a bolus could be a huge problem, right? And then there's some studies that are starting to suggest that even in patients without a history of heart failure, that much fluid isn't necessarily helpful. And so a lot of times we'll start with early aggressive hydration. So I might start with a 10 cc, 10 milliliter per kilogram bolus and reevaluate continually. And the big kicker here is going to be our volume status assessment. And so sometimes you might want to give more fluids if they can tolerate it. And sometimes you might actually start going to um, uh, vasopressors like noradrenaline or norepinephrine for blood pressure support. And I'm curious to know what you guys use to assess somebody's hydration status.
So Dr. Damallash from Ethiopia speaking.
Welcome.
So thank you very much for the session. And on this particular case, what we would have done in our emergency room is we will try to give 250 ml of normal saline challenge, and we check the lung condition after the fluid by checking the saturation, auscultation, and also we have point of care ultrasound. We can scan the lung and we check for B lines, and also we check for IVC diameter, inferior vena cava diameter, and we'll check the collapsibility and distensibility index of the IVC. After we do that, we will determine whether or not we should go with the next challenge of another 250 ml, because if they develop pulmonary edema, the requirement for CPAP would be there, and we couldn't afford that left and right. So we really are cautious in fluid administration.
Yeah, I love a bunch of things about what you said there. One is that you did it incrementally, right? So you started with a little bit of fluids, saw what happened. Give a little bit more, saw what happened. And then after my own heart, I'm a huge fan of ultrasound. And one of the things that is really common with some of my coworkers is they use the ultrasound to look at the inferior vena cava a lot to see is it still is it now dilated, or is it still collapsible, or how variable is it with an inspiratory sniff to suggest and my understanding is the evidence is starting to suggest more, not necessarily whether they be fluid responsive, but sometimes it's more fluid tolerant. And so it might not necessarily say whether we're volume down or not, but it might suggest whether or not they can handle more. um I like that you're looking at the lungs as well, right? And so if we start seeing a pulmonary edema, it might suggest that we've definitely maxed out how much fluids we might be able to give and might want to go to another approach. Because as I think you're kind of suggesting with this incremental approach, is once you give it, you can't take it back very easily, right? You don't want to give a bunch of fluids and now they're volume overloaded, and now you have to treat overload. Um, so I like those points. And then somebody mentioned in the chat skin turgor, looking at their mucosa, their blood pressure, their pulse rate. Wonderful. I love that as well. One thing I've actually heard a little bit about as well is using ultrasound to assess the jugular venous pressure, because some people it's hard to see. And so you can actually use ultrasound to assess height in that. Um, no, I very much agree with you. Like small aliquots of fluids and go from there. And I'm curious, Jess, for your thoughts. I feel like a lot of times once I've given 1 to 2 liters of fluids, even if I haven't reached 30 milliliters per kilogram, oftentimes the amount of blood pressure support that I'm going to get is kind of maxed out. Like they might tolerate more fluids, but if I'm already 2 liters in, the likelihood that the 3rd liter is going to be sufficient for all their blood pressure support is oftentimes anecdotally not common.
Yeah, I agree with Dr. Nick on this. So specifically for a patient with sepsis, if you've already gotten to about 2 liters of fluid in an adult patient, it's unlikely that giving any more fluids at this point are going to be helpful, unless they are truly also dehydrated. So that's important to look at your clinical exam. I know folks in our setting come in a lot earlier than they do in some other settings. And so someone may be much more volume down where you work compared to where Dr. Nick and I work. And so you do have to look at the whole clinical picture. But yes, I agree that if you've got a sepsis patient, if you've hit 2 liters of fluid resuscitation, at that point, you may want to consider vasopressors if that's something within your scope and something available to you. We'll talk more specifically about just plain dehydration toward the end of our presentation today. And thank you to everyone who's responding in the chat with excellent questions. We're going to move to what is the volume status assessment? Dr. Nick, do you want to chat about this a little bit?
Absolutely. I have a great link for that my friend, one of my best friends is an ICU doctor actually. And so he sent me this piece on jugular venous pressure. And so it's currently my messages are not on this computer. So I'm going to try and get it put in the chat here for Nakamuli, Agnes, but so I'll put that link in the chat in just a minute here. But so here's some of the things that we can use for volume status assessment. And actually, this is one of those things I was giving my friend a hard time about. So I was like, hey, Ben, in the ICU, so he did internal medicine and now he's doing pulmonary and critical care medicine. And so we have very different backgrounds in medicine. So I like to learn from people who train differently than I. And I was like, Ben, all right, how do you assess for volume status? And then after I sent that message and I said, without using intake and outtake or intake and output and without using daily weights, right? Because that's a resource I don't have the luxury of in the emergency department. And he's like, well, admittedly, I use input and output and daily weights. And part of the problem is because we have these tools here, heart rate, blood pressure, skin turgor, sometimes orthostatic vital signs, using ultrasound to assess the IVC. Sometimes you can see if they're volume overloaded, but that pulmonary edema, like the other doctor had mentioned. Sometimes mucous membranes can be helpful if they're really dry. Sometimes if people are very familiar with their weight, that can be helpful. So patients who are on dialysis or sometimes with heart failure and things like that, some people are very familiar with their weight and they're told to track it specifically for volume status and urine output. But the problem is none of these is really definitive in and of itself, right? None is inherently necessary and none is inherently sufficient. And so this is one of those things where we have to put all the pieces together to kind of inform our gestalt. The other thing too is some studies suggest that the inter-rater reliability of these is very variable as well. So what you think is poor skin turgor, I might think isn't that bad, or I might think that their mucous membranes are fairly moist, but you might think that they're a little bit dry. Orthostatic vital signs have also started to become kind of controversial. There was a study out of Australia that found 40% of patients who presented to Australian emergency departments had positive orthostatic vital signs, even in a setting of not having like volume related complaints that brought them to the emergency department. So sometimes they're really helpful, but sometimes they might be misleading. And so these are some of the things that you might take into your calculus when trying to assess people. But again, I love Dr. Is it Nagatu? His incremental approach and heavy use of ultrasound. It's a nice non-invasive way to get a lot of information.
Dr. Nick, one thing too that someone brought up in the chat just a moment ago, actually Dr. Nagatu mentioned the passive leg raise test. That's something I use frequently in my practice as well, and I think is a really great test. So essentially you hold up the legs for a couple of minutes, and you just watch the mean arterial pressure, you watch the blood pressure, and you check and see if that improves the blood pressure and mentation and things like that. And essentially, you're giving the person a fluid bolus, right? Because the legs hold a lot of fluid. So even if you're just putting the patient in Trendelenburg position, all of that fluid is going to move back toward the heart. And if that actually increases their blood pressure, it can give you an idea of whether the patient's fluid responsive. And like Dr. Nick mentioned, that's not a perfect test. Dr. Nagatu also brought up capillary refill, and I agree with him. That's such an important test that's so easy to do, and I think we forget. So remembering to check that at the bedside on our initial examination, and then again, every time we reassess the patient after each fluid bolus to see whether their capillary refill in the setting of sepsis or septic shock is improving, to know whether you're making a difference. Thank you for bringing that up, Dr. Nagatu.
All right. So then we'll go on to another case here. If you move forward, Jess. So this case 3. So you have a 24-year-old female with insulin-dependent diabetes who presents with body aches, nausea, feeling generally unwell, and she ran out of her insulin a week ago and has just been feeling bad ever since. Her blood sugar reads high on your glucometer. Blood pressure is good, heart rate a little tachycardic. And you notice small respiration, so breathing fast, taking deep breaths. They're oxygenating well and they're not febrile, but they have some dry mucous membranes. And the rest of your exam is unremarkable. So what do you think's going on, and what would you like to do for her? And specifically, when you hydrate her, what would you like to hydrate her with?
And feel free to chime in out loud or in the chat with your response to Dr. Nick's question.
Right. So I think what we're trying to lead towards here is diabetic ketoacidosis. And to be fair, they we can see similar presentations with not DK. So if somebody has non-insulin dependent diabetes, they can still get very severe hyperglycemia. But in this setting, it's like one of the things that is commonly an issue with insulin is it needs to be refrigerated. And so if power cuts out or things like that, they might not have access to their insulin anymore. They might have not been able to afford it. I frequently see patients that come to the emergency department after their insulin gets stolen. And so like they get their backpack stolen that had their medicine in it or things like that. And so then this presents. And so, yeah, so we think diabetic ketoacidosis is going on. And so then how do we want to treat it? I see give more fluids, preferably normal saline. Okay. Thank you so much for chiming in. What does RBS stand for?
Oh, rapid blood sugar.
Okay, thank you.
Good. So yeah, I agree. In our setting, we use slightly different measurement system, but yes, once the blood sugar is getting toward the normal range, you need to switch to a dextrose containing fluid and ensure that you're repleting the potassium if the patient is hypokalemic or normokalemic while you're giving those fluids, because insulin will shift the potassium intracellularly.
Yeah, and this is one of those things too, where even though their potassium might read as high, their total volume might be down. And so you have to be ready to keep repleting it. I'm curious, what solutions do you have access to intravenously? So I hear normal saline. I presume DS is dextrose solutions. Does anybody have lactated ringers or Normasol or Plasmolite or anything like that?
So Dr. Nick is asking whether you have access to balanced fluids.
Yeah. I think RL is Ringer's lactate. Is that correct?
Yeah.
Dr.
Yes.
Perfect. Yeah, so I think oh perfect. Thank you for chiming in as well. I love the activity in the chat and people speaking up. Yeah, so I think there's a couple reasonable choices here for sure. One of my favorite quotes in medicine I heard in medical school is reasonable people can disagree, right? There might be multiple appropriate ways to go about it, and one might be preferable in your setting or for your style versus something else. So this is one where I think normal saline or Ringer's lactate are appropriate to start with. These patients tend to be very volume down. They oftentimes need a lot of fluids to get euvolemic again. And normal saline is a traditional, very acceptable one to start with. Our protocol at our hospital, we have like an order set. So when somebody comes in and we find that they're in diabetic ketoacidosis, there's a protocol that starts, and it starts with a bolus of 2 liters of normal saline before even starting like a maintenance infusion. And I tend to be a big fan of Ringer's lactate, lactated Ringers, or Plasmolite or Normasol. And if Jess can cycle forward to the next slide, I'll talk a little bit about why. So this is a table I made of some of the features of some of these common solutions. So your standard plasma, like your blood, has a sodium of 135 to 145, chloride of 95 to 110, osmoles of 291, and a pH of 7.35 to 7.45. Normal saline has a sodium of 154 and a chloride of 154, and its osms are 308. So it's a hyperosmotic solution. And interesting, I think something people forget a lot is the pH of normal saline is about 5.5. So it's super acidotic. And so we have somebody who's already acidotic, and then we pump them full of acid. And we also see this is part of, I think, why we use less normal saline in trauma. I think some of the outcomes get a little bit worse because acidosis gets worse, or acidosis is super important to avoid in trauma. And giving normal saline in trauma, it doesn't help you with oxygen, but it's also acidic. So Ringer's lactate is starting to get pretty popular as well. And part of it is it doesn't give you this big chloride load. So its chloride is only 109. And so this can help you avoid hyperchloremic metabolic acidosis. So when you give really large volumes of normal saline, you give them a really large chloride load, which is a negatively charged anion. And so it can shift your bicarb into cells or renally excrete it. And so then you can get a metabolic acidosis. Now, this has been studied in some really big studies, and oftentimes the difference is fairly nonplussing. Like it's not a very big difference. But sometimes when you're giving large volumes of fluid resuscitation, you'll start to see that difference a little bit. So my personal bias is I tend to use a lot of Ringer's lactate. But I freely admit, I don't think it really makes that much of a difference, except for maybe when we're doing really large volumes, like super dehydrated patients, like in diabetic ketoacidosis or in sepsis, sometimes it might make a difference. The other nice part is it's got a little bit lower of a sodium as well. And I think that can be beneficial in some aspects. The other one you'll see is Plasmolite, sometimes called Normasol, or it's another form of balanced crystalloid solution. So this has a sodium of 140, another physiologic electrolyte of chloride of 98. Osms are very similar to physiology, and its pH is 7.4. So even better for preventing or helping in the setting of acidosis. I think one of the drivers between the frequency of Ringer's lactate and Plasmolite is oftentimes cost. So Ringer's lactate tends to be more expensive than normal saline, and Plasmolite tends to be even more expensive than the Ringer's lactate. But depending on your geography and just shortages, that might change. So there was a hurricane over here a while ago, and one of the main producers of IV crystalloids was affected by that hurricane. Not only was the factory damaged, but also access to it was limited. So like a massive portion of the US went on critical shortage of IV fluids because we couldn't access the factory and the factory couldn't continue producing fluids. And so what's available might change pretty drastically for you.
And it sounds like that fluid shortage impacted many of you as well. I know colleagues in the Gambia messaged me that they were having the same problem getting fluids, since our fluid producers here actually supply a lot of international fluids. So we thought this was a really relevant topic. And it's the reason I sent out that EM Docs blog post. We wrote it in response to the fluid shortage. So hopefully this is helpful for, if you have to make choices with what you have available, making a wise choice as to what's best for your patient.
Oh my gosh, I love this activity we're having in the chat. Thank you everybody for chiming in and getting a lot of people from new places too. I'm seeing the Congo, I'm seeing people from Lagos. That's awesome. So the next case is an 8-month-old male that presents with vomiting and loose stool. There's no blood in the vomit or the stool. There's some decreased feeding, no fevers, focal weakness, abnormal movements, neck stiffness or rashes. The exam's notable for a sunken fontanelle, and norovirus is known to be present in the community. Vital signs are a heart rate of 180, a respiratory rate of 40. Nice, Jess. Sorry, Jess sent me a message. Uh, temperature of 36.6 and an O2 sat of 98% on room air. Blood pressure is 80/36. And the question is, does this patient need IV hydration? Why or why not? And I think this gets at a couple interesting things. You guys might be even like drastically better at this than myself here. Uh, I don't know how often you see norovirus. It's going around where I am geographically right now. I think I had it last week, and boy, would I tell you, the descriptions are accurate. But with little kids, a lot of times they'll get through these things, but they need the supportive care in the process. And what I try to do with this description is lead away from it's not cholera. We don't think they're meningitic or things like that. We think it's primary of volume depletion in the setting of a viral syndrome that will hopefully be self-limited. But the question is, do we need to do an IV to hydrate them, or are there other ways to hydrate them, or do we think that they need any supportive hydration, or they can just try and get supportive care at home?
And that rehydration approach will be similar whether you're dealing with a bacterial or viral associated diarrhea. Obviously, if it's some sort of bacteria that's present in your setting and you need to specifically treat it with antibiotics, then please do that. But we're only focusing on the rehydration component. I saw someone in the chat mentioned this person may need IV fluid or an intraosseous line because of severe dehydration with vomiting. Another person said if they're able to drink, then no need for IV hydration. So there's a lot of good points with both of those.
Yeah, I like with the drinking one, how much do they need to be able to drink, right? Like here in our children's emergency department, we have popsicles, right? I can get a child to get over a lot if I bribe them with a popsicle, but popsicles will only get me so far, right? How do I know that they can drink enough to hydrate appropriately?
Yeah, so I like that someone responded. If they're not able to keep up with losses, then you need IV fluids with dextrose, and I would agree with that. And someone else mentioned you need a fluid bolus. Yeah, so for severe dehydration, if they can't drink especially and they're too sleepy to do that, probably giving an initial fluid bolus, if you end up giving IV fluids, 10 to 20 mLs per kilogram, ideally 20 mLs per kilogram to help resuscitate them. And then I think giving both IV and oral fluids, once this person's able to take oral fluids, is a great idea. Dr. Nick, do you want to touch on like NG rehydration for kiddos who can't drink?
Absolutely. Yeah, and I think the other thing that this case pushes too is I don't know how many kids you guys see, but I know oftentimes in the US, a lot of emergency medicine doctors primarily focus on adults, and then there's some that go specifically into pediatric emergency medicine. And so like when you like say like if you were to walk into my emergency department and say we have a baby with a heart rate of 180, people would like freak out, right? And so it also kind of pushes you to think about what normal vital signs are and abnormal vital signs are for kids. And if you don't know where you're going to find that answer. So do you have like a reference chart in your emergency department to try and figure out what's safe and what's not safe? But this is a good case where I love the idea of oral rehydration. If they can drink enough, I usually think about, especially for babies, 3 to 4 wet diapers a day. There's a great piece of Dr. Katena in Mother Mercy Hospital in South Sudan, where he's rounding and there was a baby that was admitted for dehydration. He comes and rounds in the morning and they have a wet diaper. He's like, this is a great sign, right? So if we can still wet diapers, and if we can eat and drink enough to have multiple wet diapers a day, that's reassuring. But one of the other good options we have is nasogastric tubes to feed. One of the things that there's actually a decent amount of literature in, which I recognize I need to be a bit more cognizant of, is that IVs are not benign for kids. They're painful and trauma inducing. And so if we can avoid them, it's really preferred for their long-term relationship with healthcare and outcomes. And there's things we can do to minimize the pain and trauma associated with it. But sometimes little babies will tolerate NG tubes well. And so sometimes you get to avoid an IV, which can be a resource limited thing sometimes. It can be a source of infection. It can be a big expense, especially because sometimes it might take multiple attempts to get an IV. And so sometimes you can get a nasogastric tube in and hydrate them that way. And so I like your 20 ml per kilo bolus, and reassessing could be a great choice.
Dr. Nick, I'm actually going to skip ahead from here to the protocols because someone said we have a chart for this, and that is correct. We'll come back to case 5. This is a perfect segue. So I don't have clinical guidelines for Nigeria. I've asked many times. So if there's anyone on the call who has access to those, please do share them. But we'll go through the Ugandan and Gambian clinical guidelines. So if a kiddo is looking pretty darn dehydrated, you got to grade the severity of that dehydration. So are they moving on their own? You know, if this is someone who is so sleepy from dehydration that they're not moving around, then they are someone who needs IV or IO fluids. Restlessness and irritability, sunken eyes, these are all signs of pretty severe dehydration. Someone mentioned earlier the value of capillary refill and skin tenting. Make sure to check those things on these kids and see how slowly that skin goes back to baseline. So if it's severe, then IV or IO fluids are warranted, and it's, you know, they're probably not even going to be aware enough at that point to be upset about having to go through the pain of accessing their vascular system. Now, looking at severe dehydration, again, give IV fluids. But if someone has moderate, then you can consider oral rehydration solution or breastfeeding if it's a small baby, if they're able to do those things while you are trying to get access and give them fluids. So this is kind of referring to folks in the outpatient setting, mentioning that you need to refer urgently to the hospital while the patient is rehydrating. And then if someone is rehydrating orally just fine, then you can do outpatient follow-up and continue doing oral rehydration solution or breastfeeding depending on the age of the child. And it's important to emphasize that that oral rehydration solution needs to be made using clean water, right? Because we're just going to exacerbate the problem, unfortunately, if we're using non-boiled water or tap water that's not sanitary. So making sure that it's safe, clean water so that we don't end up getting additional infections. The Gambia has a similar set of clinical guidelines for how to rehydrate kids based on the level of severity of their dehydration. I like this table a lot. I think it's quite clear. But so if kids are not dehydrated, then give them fluids and food, and then have them follow up outpatient. But if they have mild dehydration, meaning that they're restless, irritable, sunken eyes, and their skin is tenting, but they are still drinking eagerly and thirsty, then this is someone who can try oral rehydration and reassess. But the patient with severe dehydration really needs IV fluids versus NG tube fluids, depending on what resources you have available. Feel free to chime in the chat if you have thoughts, feelings, experiences regarding this, and whether your institution tends to jump right to IV or IO fluids, or whether they go to nasogastric rehydration, depending on what resources you have. So again, please mention in the chat what your institution does. We always love to hear. We're going to come back to case 5 while people chime in the chat.
And also, Jess mentioned we have the guidelines for Uganda and the Gambia. but it's I think today we have people on from multiple other countries that are new to the Journal Club. So if your country, so I think we might have representatives from Ethiopia, the Congo, or Democratic Republic of Congo, I believe I saw, and maybe South Sudan as well, potentially. Like if you have guidelines for your country, we would love to see those as well. So that way we can share those and get more international knowledge sharing and collaboration going on, because I think one of the really cool parts about emergency medicine in Africa right now is that it's growing so rapidly and there's so much to learn from each other. So feel free to share your knowledge. We'd love to learn from you. So for case 5, we want to talk about a 19-year-old female who comes in with a history of kidney stones, has a history of kidney stones and presents for left flank pain and hematuria. She reports it feels like her prior kidney stones and her vital signs are within normal limits. And so for the sake of the case, we'll presume it is a kidney stone, right? I mean, it could be ectopic pregnancy, it could be ovarian cysts, it could be an abscess. There's lots of things it could be. Let's assume there's also not a concomitant infection. We just think it's an isolated kidney stone. Do they need IV hydration, and why or why not? And remember, reasonable people can disagree. But don't be afraid to share. Thank you so much for chiming in, everybody. I'm seeing in the chat that hydration can help passage of stones depending on the size, and it also stops the clots from forming. We're also seeing that they might not necessarily need IV fluids. But again, after my heart, assessment of her fluid status is a priority, right? Yes. I'm a big fan of sassy sayings, and one is the idea. So I'm all about evidence-based medicine, right? But what we need to be able to do is take the research that we see and figure out how to apply it to our patients. If we can only do what a research study says, that makes us a technician rather than a clinician, right? Clinicians are supposed to take the evidence, the research, and the knowledge and apply it to the person in front of them. So yeah, that always starts with the assessment, because you don't know if the research applies until you assess your patient. And that's part of why we have to make sure protocols fit the patients that we're working with, and that can change a lot. I think Jess can definitely chime in more. She's a little bit more familiar with some of the research behind specifically renal colic, but this is one of those things where historically, oftentimes we give IV fluids for with the idea that hydration helps pass the stones. And personally, myself, if I had one of these, I would want hydration. I think that would help me have a better chance of passing the stone. But my understanding is that, and Jess, correct me if I'm wrong, the research doesn't necessarily support that it improves speed of passage or success of passage.
Correct.
But also, we can hydrate orally as well.
Yeah, I agree with Dr. Nick. I think this is kind of a myth that we continue to perpetuate in the emergency medicine world, that IV fluids help with stone passage. There's actually not great evidence for this. And giving IV fluids can increase the systemic volume and then actually cause a little bit more pain, since you're sort of like trying to force the stone out. So this is something to consider, like if the patient is dehydrated because they've been vomiting nonstop because they have bad renal colic, then absolutely give them IV fluids or give oral rehydration solution depending on the degree of dehydration. But you don't necessarily need to give IV fluids to help with stone passage. It looks like Constant has a question. Go ahead, Constant. You can feel free to chime in either in the chat or you can speak up out loud.
Good evening, everyone. Thank you for giving me the floor. It's not a question I'm having. I just wanted to explain why I said I cannot give IV feed to this patient. However, you have done it. There is no need for me again to explain it. What you said is quite normal. There is no need for us to give IV feed to that patient because currently is having pain and it will increase the volume of urine, what will worsen patient pain. But later soon we can do that. There is no evidence for us for the hydration.
Yeah, I agree with you. There's not great evidence suggesting that rehydrating with IV fluids is necessary in this situation. Again, it's a common myth.
I think there's also something to be said about too, where a lot of times as providers, we feel pressured to do something, and there's the expectation that we do something to make patients feel better, right? Oftentimes, and we'll see this with lots of stuff. For example, IV fluids for heavily intoxicated patients, like people who are really drunk. They'll get IV fluids, but it doesn't speed sobriety, it doesn't improve outcomes, but a lot of times it's done, right? Or patients sometimes feel more cared for, things like that, but oftentimes it doesn't improve their outcomes. It just increases expense. And then sometimes we have to recognize there's nothing magical about IV fluids, right, versus oral fluids. I freely recognize that whenever I get sick and develop a headache, and I think it's because I'm sick, I drink a bunch of water, right? It's not any it doesn't need to be IV fluids. You know, if I'm dehydrated, I need to hydrate. The delivery mechanism is sometimes less important. But like and I think maybe to Dr. Nagachu's and Dr. Agnes's point, I know somebody else was on there too. We might want to hydrate if we think they're volume down, right? If they're in a lot of pain and they're nauseous and they're vomiting, and we think they're now dehydrated, maybe they have a kidney stone and are dehydrated, right? And so depending on the patient in front of us, it might not always be the same answer.
Someone else brought up an interesting point. They said, wouldn't consider fluids unless there's severe hematuria. Remember, giving IV fluids isn't necessarily going to get the clots out of the bladder. So that person may need irrigation of their bladder if they have severe hematuria. We don't see that very often with kidney stones where they're having such bad hematuria that they're developing clots, but it could happen if someone's on anticoagulation, something like that. So I would only irrigate the bladder if they are having such bad clots that they are retaining urine. And you can assess that, you know, by palpating full bladder and the patient says they can't pee, or you can do, you know, a bedside clinical ultrasound to look for urinary retention. So looking at post-void residual urine volume.
Mm-hmm. And it also has the uses, I'm not sure if it was mentioned, but assessing for the hydronephrosis, right? And you know, if you have severe hydronephrosis, and depending on how big the stone is, it might change how you manage the patient as well.
All right.
I think that's all we have for cases. We've already talked about some of the guidelines a little bit, and we also have a little bit of time too. So for a wrap up, IV fluids are unnecessary for a lot of the things that we do. We can use them a lot more judiciously than I think a lot of times we think, right? A lot of times there might be the pressure to act, but it's a take on the saying, don't just stand there, do something. Sometimes we need to just not do something, we need to stand there, right? Like we don't necessarily need to give them lots of IV fluids. Sometimes we give them a bottle of water. For moderate dehydration, we can give IV fluids if oral rehydration fails. But severe dehydration, a lot of times we do need the IV fluids though. We can consider dextrose. Oh, and Jess, did you touch on the dextrose containing fluids and thiamine?
No, I did not. So I'm going to bring that up here actually. So some of the folks chimed in earlier in the chat about dextrose containing fluids. So situations where those would be helpful, obviously in diabetic ketoacidosis or DKA, once your sugar is approaching a normal range and you still need to continue insulin in order to resolve the anion gap, those people obviously need dextrose containing fluids to prevent them from becoming hypoglycemic. But other situations where dextrose containing fluids would be helpful are kids who are dealing with malnutrition and dehydration and are at high risk for progressing to hypoglycemia or already suffering from hypoglycemia. Someone else just asked a question about colloids in trauma. Rebecca, do you want to actually speak up with your question?
Number class le. Kung bangela ko ini ko nyanya. Nimpare dama.
Rebecca, do you want to chime in with your question out loud? We didn't cover trauma today, but remember that if someone's bleeding, you want to replace blood with blood, right? So I would avoid giving IV fluids in the situation of someone who is hypotensive or shocky, because they are bleeding, right? Because unfortunately what happens is we cause coagulopathy when we give IV fluids to patients who are losing blood products. In a lot of your settings, you have access to whole blood, which is honestly way better than what we have here. We typically give 2 units of packed red blood cells, followed by, if someone is, you know, in shock, we give massive transfusion protocol, which means we give a 1-to-1-to-1 ratio of red blood cells to platelets to FFP or fresh frozen plasma. Thank you, Dr. Nagato. You just mentioned 1-to-1-to-1. I totally agree. So if you have whole blood, you have all 3 products in the whole blood already. So you don't need to think about the 1-to-1-to-1. But for people who are in a setting like ours, where we don't always have whole blood, we often have to think about giving separate blood products. There's a couple other questions coming in the chat. Someone here said colloids are expensive and have not much advantage over crystalloids. I 100% agree with that. I don't give colloids other than giving albumin to folks who are in some sort of shock related to cirrhosis and sepsis. Or if they had a large volume paracentesis, you can give albumin, but I agree they're expensive. They add an extra level of possible infection risk, and they don't have any advantage over crystalloids for people who just need IV fluids. Someone else mentioned, can you make note of how to reconstitute dextrose containing fluids in settings where no prepared solutions are available? I can share that information in the WhatsApp group with you, Faith. I don't think I'll be able to grab it right now since I'm screen sharing and can't get on my internet, but yes, I would be happy to share how to reconstitute that. Other questions here. Someone said that IV fluids are also controlled in malnutrition unless in hypovolemic shock. Rita, would you mind clarifying that question a little bit for us? Oh, I see what you're saying. So for severe dehydration with hypovolemic shock, then that is the situation where you're giving IV fluids. I think that's what you're getting at. And yeah, I agree. Based on the guidelines we shared earlier from Uganda and the Gambia, I would not give IV fluids unless someone cannot drink and they're in kind of a shocky state. So very delayed capillary refill, they're too ill to drink, that sort of thing. One other thing I did want to mention today, since people are talking about dextrose containing fluids in the chat, that if someone has not been eating for quite some time, you may want to consider giving thiamine as well, since there's a theoretical risk of inducing what's called Wernicke encephalopathy. So for our patient population here, for Dr. Nick and I, if a patient is an alcoholic and they have not been eating for quite some time, they're very high risk for developing Wernicke's encephalopathy if we give them dextrose containing fluids or let them eat without giving thiamine first. And that also goes for patients who are anorexic, patients who are experiencing malnutrition. So if you have thiamine available, it may be a wise idea to give that with your dextrose containing fluids. Someone just asked in the chat if we can share our WhatsApp group. We have a global community that's shared with 19 low and middle income countries. The journal club invites actually do not get shared on there, since our journal clubs are specific to our African partner sites. We try to go with guidelines that are relevant to you. So you can certainly join the global community here at the link I just sent in the chat. Another option, you can text me directly on WhatsApp and I will put my phone number there. If you would like to be added to a WhatsApp group in Uganda, in the Gambia, or some other location in Africa where we do share the journal club invitations, and I'll continue to share them on the ECHO invitations or ECHO WhatsApp groups too. At this point, I am going to share the survey link. We would really appreciate it if you guys could share, or rather, if you can fill out the survey so we know how we can better cater to your questions, your needs next time. And we want to thank you so much for coming today. Dr. Nick and I will stay on here for about another 10 minutes so that we can take any questions that you have either in the chat or out loud. If you're not speaking, please mute yourself. Thank you all so much for being here. And someone just asked if I can reshare the link again. I will again share the global community link in the chat. Please remember to fill out the evaluation so we can make this better for you. And thank you so much. Big thanks to Dr. Nick, who did the bulk of the work today. with preparation, and thank you for being so engaged. This is the most participation we've had at a session in a long time, so we're very thankful for that. Dr. Nick, do you have any final closing thoughts for the group?
Thank you. No, just thank you so much for everybody for coming. Thank you so much for being so active. I love it when we get discussion and knowledge exchange rather than delivery, right? Like I love going over some of these topics, but I really love hearing what you guys do and how you do it, so I can learn from you and you guys can teach each other as well. So I always think that's really exciting.
Can you please elaborate on maintenance fluids, how to calculate and how to account for losses like diarrhea? That's a really great question that I don't know that we'll have enough time to dive into thoroughly today, but actually, can you guys see my internet right now? I'm sharing an MD Calc screen.
Yeah, we can see it.
You can see it. Okay. If you have access to internet at the time that you need to calculate maintenance fluids needs, this is a really good option. So let's say I have a 60 kilogram individual. I can go on MD Calc, type in maintenance fluid calculations. There are ways to do the math on this, but personally, I'm not great at math and I don't really have time to do math. So I would prefer to have this do the math for me. But this application will give you the maintenance fluid rate and then the 1.5 maintenance fluid rate for someone who's quite dehydrated. And then I think you actually asked too how to account for losses. So generally it's great if you can sort of gauge the volume of the stool or the vomit that someone lost in order to replace that with oral rehydration solution or IV fluids. And so strict intake and output, I think, is really the best way to do that. And Dr. Nagatu just shared a really nice protocol here for how to calculate maintenance fluids if you don't have internet access at the time that you are hoping to give those fluids. So thank you. I'm the worst at math. So props to all, or, congrats to those of you who are good at math. Yeah, feel free to put any other questions in the chat here. We'll stay on for a few more minutes.
And also, if there's topics you think of that you would like discussed in future months, feel free to put it in a survey or message us. We're always looking to try and make sure that these are topics that are of interest and utility to you.
It looks like we had a few people pop on at the last minute. So if you did not already put in the chat where you're joining us from, please do that.
Also, hi, Booba.
Hi, Booba. Awesome. Well, we're going to wrap up here. Again, you can message on WhatsApp if you have specific questions. You can also put feedback in the survey. Someone asked for a session on shock, which I think is a great idea for maybe next month's topic. So thank you for the suggestion. All right. Well, with that, I think we are actually going to close for the day. Thank you again for being here. If you didn't already share where you're joining us from, please put it in the chat. Please fill out the evaluation. I will share the link one more time. Message me directly on WhatsApp if you want to be added to one of our continuing medical education solutions chats. And with that, we're going to close. Thanks all.
Bye, everyone.
Still have people joining an hour late. Sorry, I'm going to close this for the day.